filled out the little survey I sent out several weeks ago. Thank you to both residents and faculty. I was mostly just curious about how we all think about autonomy here. And there are some important takeaways, even with a relatively small response. So the key points from the autonomy survey for faculty are that there is some uncertainty about how autonomy is measured and reported by the ACGME. That resident autonomy seems to be on the decline compared to faculty's era of training. That residents' expectations for autonomy can sometimes outpace their level of training. And finally, that faculty generally are comfortable discussing expectations around autonomy with residents. For faculty, autonomy means graduated responsibility and trust that's based on some type of observed performance. Respondents commented that the resident's role in acting autonomously means that they get the first opportunity to do the assessment, the plan, come up with a differential diagnosis, but that those steps should be reviewed with an attending prior to implementing the plan. And the OR faculty see that autonomy means giving residents level appropriate technical components of the case to complete, and that if there's decisions made in an operation, that decision is made in concert with the attending. And then one faculty also stressed the importance of respecting the patient's autonomy in their selection to have an operation, emphasizing that decisions around definition of autonomy don't always occur in a vacuum, and it must include the perspective of our patients as well. So from a resident's perspective, residents also feel uncertain about how autonomy is measured by the ACGME. Residents do feel like faculty generally give them an appropriate level of autonomy, and feel overall like they haven't, that they have that level of autonomy. However, there's some variation in the level of comfort that residents have when discussing autonomy with their faculty members. To residents, autonomy means an openness to difference in opinions and decision-making and technical approaches, with residents being allowed to kind of struggle safely. They asked for things like deference to faculty preference and allowing them to do things that might be related to their own preference from what they've seen other attendings perform. Others commented on being allowed, again, to struggle safely, along with being able to participate and perform as much of the operation as possible. In all, there were several areas of agreement. So there is overall uncertainty about how autonomy is defined, measured, and reported. And we do kind of recognize that both groups, faculty and residents, see that there's a component of graduated responsibility in autonomy. There were some areas of less agreement. So there's a little bit of a difference between everyone's comfort level in discussing expectations around autonomy. And there's maybe also a little bit of a difference between the importance of deference to a faculty difference or tolerance of difference in a clinical setting or in the operating room. So with that general landscape in mind for what autonomy may or may not look like here at Creighton, I want to go over a couple of objectives for the rest of my talk. The first is to define autonomy and describe the one particular framework for how we might be able to better understand autonomy in a clinical setting. We'll outline current measures and reporting for autonomy. We'll describe current data on whether trainees are prepared to be autonomous surgeons when they're finished. We'll talk about current barriers to equitable autonomy, and we'll explore interventions that promote autonomy across multiple settings. And then at the very end, we'll kind of contextualize the importance of autonomy for patients and also for resident well-being. It's kind of a long list. We're going to get started. In the broadest sense, autonomy is the ability or right of an individual, group, or system to make their own decisions independently and without external control or other influence. In a clinical setting, autonomy really means the extent to which a trainee can function safely and acting of their own volition. Autonomy is something that's granted, something that's earned. It's informed by both competencies and milestones, and those are practiced under graduated levels of responsibility. As with all nuanced topics in medical education and surgical education, autonomy doesn't happen within a vacuum. It means finding the right balance between patient safety and also learning. One framework that I found particularly helpful to approach this discussion around autonomy is something called the ARTS framework. So this is a type of scaffolding that was developed with a grounded theory approach after interviews with surgeons, centered around the question of how attendings construct trustworthiness and make entrustment decisions when they're granted autonomy. This group identified four main elements to how faculty grant trust to trainees. Those are approach, relational skills and competencies, technical skills and knowing limits, and solidarity. I'm going to go through each of those. So approach is all about how residents approach problems. It's how they use problem-solving techniques, their attitudes to daily tasks, and things like unexpected challenges. And then it also means just generally being prepared. Residents who earn trust in this particular domain are structured, they're well prepared for procedures, pathology, anatomy, and also creating differential diagnoses. For relational skills and competencies, this is all about relationships between residents and attendings. Collegial relationships are those that have valuable characteristics like humility, kindness, honesty, empathy, and respect. Residents who earn trust because of their relational skills have an interest in perceiving or developing a personal relationship with their faculty member. They're kind, they're honest, they're empathetic, and they take responsibility. They show good character, and they communicate respectfully. The next is technical skills, and this is kind of like the most intuitive element of this framework. It's all about recognizing technical skill, and importance is placed on things like ambidexterity, hand-eye coordination, having calm and secure movements, having tactile expertise, and visual spatial acumen. Most importantly, however, this element also includes a component of self-awareness and technical competencies. So surgeons place value and trust in residents who have a strategy and a steady hand. Trustworthy residents are those who know their limits. They know when to call for help. They have an operative strategy in mind. Ultimately, this element is about placing trust in residents who are not just doing surgery, but doing the surgeon. And the final component is solidarity. So this is at the level of the residency and the program at large. Trustworthy residents have a track record of being a good and fair colleague. They're engaged in the department, they step up to help and go the extra mile, and they also help peers finish tasks and embody principles of teamwork and solidarity. They uphold overall the mantra that everyone is in this together. The main reason I appreciate this framework in particular is because it emphasizes the ways autonomy is granted and earned, and it's very much part of, excuse me, the hidden curriculum of surgical training. It's not only about checking boxes with explicit rules and things to follow, but it's also about walking the walk to become enmeshed in a surgical culture. The goal of the framework is to make some of these more hidden components around decisions of trust, including approach, relational skills, technical skills, solidarity, more visible. And all of those elements are also, unfortunately, the hardest to teach and evaluate, which makes studying autonomy at the broad level very challenging. So now that we have a framework in mind about how we might think about autonomy and how decisions to grant autonomy are made, I'll spend a little bit of time talking about the ways autonomy is currently measured. So there's multiple points of data that inform decisions around autonomy, but as we learned from that framework, right, there's other components that are also important and are more challenging to actually capture outside of written evaluations that reflect on some of those more interpersonal skills. Regardless, some of the most explicit measures that inform decisions are all informed by the ACGME program requirements. So the ACGME requires both formative and summative feedback. Formative feedback meaning monitoring resident learning, offering ongoing feedback within a given clinical context. And then summative feedback means evaluation of a resident's learning and progression compared to goals and objectives on a rotation or on a particular service. The summative evaluation is really what informs decisions about promotion and graduation. And this is the main mechanism by which evaluations are documented, is the ACGME milestones. ACGME milestones were introduced in 2012 with the goal of defining stages along that pathway towards competency. These are knowledge, skills, attitudes, and other attributes that align with the core competencies of all residencies. Residents are assessed on a scale from 1 to 5, representing the transition from being a novice to an expert, with the target at graduation being a level 4. Very few people are a level 5. So here's a couple of examples about what these milestones actually look like. One of the challenges, though, is that they are pretty limited in terms of their ability to use an objective assessment tool, which makes them sometimes limited by cognitive bias. They are ultimately context independent, a more recent addition to some of our assessment tools, which are entrustable professional activities, which were introduced in 2023. These were intended to better align with the concept of competency-based education, which recognizes that not all learners master the same skills at the same pace. And competency-based education focuses instead on trainees that can demonstrate competencies that are required for an effective function in their role. An EPA is basically some type of essential task for a discipline that someone can perform independently and be trusted to do so in a defined context. Unlike milestones, which are context independent, EPAs are context dependent, and they're shaped by attributes of the trainee, clinical context, and then also the nature of the activity, like if it's a common or complex operation, or if it's a rare or straightforward operation. More importantly, EPAs do map to the ACGME milestones, which is represented by this graph here, meaning that if there's enough EPAs for a single resident, there are more data points to inform decisions on milestone progression. There's also multiple other assessments for technical skills that inform autonomy decisions, including case logs, right? That's something that we all fill out and keep track of. Simple, FLS, FES. There's also the American College of Surgeons has something called the Objective Assessment in Skills in Surgery, OASIS. There's also non-technical assessments as well. These assessments are used to varying degrees as proxy measures for autonomy because there's no perfect measure of true autonomy in the literature, especially around investigations as to whether trainees are prepared for independent practice when they graduate. There's overall general concern that trainee autonomy is on the decline, and more recent residents or graduates are not prepared to be autonomous general surgeons. Here, about 75% of the faculty who responded to our survey agree that autonomy has declined since they finished training. And I imagine most people in this room have heard the statistic that 80% of current graduates go on to fellowship training of some kind. And some of you may have also heard the statistic that about 2/3 of incoming fellows have been shown to not be able to perform more than 30 minutes of a major case independently. The most common way change in autonomy over time has attempted to be measured is by review of data actually from the VA. The VA actually very helpfully tracks the degree of resident supervision for any case. So this includes if the attending is a primary surgeon, if the attending is operating with a resident, or if the resident is actually the primary surgeon without an attending script. In a retrospective review of the VASCOP data from 2004 to 2019, they looked at almost 400,000 cases. And there was a relative decrease in resident serving as a primary surgeon over this time period for all PGY levels, with the biggest difference in the PGY3 class, which is about 75% decrease in total case volumes. Another group took this review a little bit further and compared VA data from general surgery cases that actually aligned with the 12 operative EPAs from 2004 to 2020. They overall found about a 61% decrease in resident performed cases, 14.3% decrease in attending assisted cases, so the resident operating with an attending assisting them, and a corresponding 51% increase in attending performed cases. Several cases had a significant increase in PGY level as well. For attending assisted cases, including hernias, breast cases, colon resection, soft tissue cases, and cholecystectomies. And there was also a significant increase in PGY level for resident performed cases across hernias, including ventral and inguinal hernias and breast cases. This suggests a trend of seniorization, so more senior residents doing bigger portions of the cases. And overall suggests that there's a trickle up of tasks and responsibilities to more senior members of the team that used to be fulfilled by junior residents. And this is a comment from one of those papers that's kind of going back in time and thinking, oh yes, it'd be delightful if we could go back to the level of autonomy in the 1990s, but it's most likely inappropriate for the day today. The progressive and ongoing erosion of autonomy and seniorization of resident operative experience is at odds with ultimately the goal of producing a surgeon that's competent to practice independently in a time-efficient manner. Others had looked at case log data, focusing on chief cases or TA cases. So in one retrospective review of case log data from 2006 to 2023, there was actually an increase in chief numbers and TA cases, but case logs are not the whole story. They fail to capture things like independence, autonomy, case complexity, and difficulty. And one method to provide more clarity is to review the actual assessment tools that collect data on autonomy, like Simple. So this is a paper that's from the Procedural Learning and Safety Collaborative from several years ago. And they did just that. They looked at Simple data from 14 general surgery programs. They found that the level of autonomy increased overall throughout training, which would be expected, but there's still gaps. So they looked specifically at the last 6 months of training and found that 80% of residents were deemed competent and 77.4 actually reached meaningful autonomy. So maximal autonomy, near independence, supervision-only practice was only achieved for a fraction of trainees. And when aligned with ACG milestones, right, the goal is a level 4 to graduate. This places most residents at maybe at a 2 or 3 for several of the core procedures. So it remains unclear how much autonomy is necessary for trainees to achieve competence prior to graduation. We can only speculate that the correct amount of autonomy is that which enables residents to learn the skills necessary to operate independently without exposing our patients to undue risk. As any teaching surgeon can attest, achieving this balance is difficult. It's challenging to fully analyze autonomy in the literature due to limitations on our measures and reporting that actually accurately capture decisions around granting autonomy. And the landscape around understanding autonomy is also challenged by multiple barriers to equitably give autonomy to trainees. These barriers include sex, race and ethnicity, the impact of new technologies, and also poor expectation setting. As is true across domains outside of medicine, the female trainee experience in residency differs from their male peers' experiences with autonomy. So female residents perform fewer operations compared to their male colleagues, and that can represent up to a loss of about 1 to 3 months of experience. In focus groups with residents exploring the female resident experience in particular, one group described that gender-dominant culture norms continue to exist in residency training and the effect on the operative experience of female residents. They identified themes like uncertainty around peers' experiences, differences in interpersonal interactions, including things like microaggressions, perceptions of competence and communication style, and then the overall burden of non-operative floor work, which female residents tend to feel a greater sense of responsibility for, and that subsequently impacts their operative experience. Overall, resident participants in this focus group study desired a system of explicit graduated autonomy that would minimize bias about personality, gender, and assertiveness. This was followed up by a survey of 21 residency programs, also aimed at exploring contributors to gender-based disparities in case volumes. More than half of respondents felt that gender affects the quality of their training, and the most common barriers noted included floor work or clinical tasks, along with sexism and gender bias, including misidentification, feeling unwelcome, and poor trust and autonomy. One resident in particular noted that she felt that she fell more often into the assistant role rather than the primary role compared to her male colleagues. Overall, this group suggested that program level review and setting clear expectations about case assignments as interventions that might be helpful for more equitable autonomy. The same group also assessed barriers specific to residents who are underrepresented in medicine. Of this same sample, 62% of residents who are underrepresented in medicine reported barriers to obtaining case numbers, and a similar number agreed that their quality of training was affected by race and ethnicity. Common themes to barriers included clinical and administrative duties, hierarchy and other learners, and insufficient cases to share, along with lack of invitation to the OR. Another theme was feeling the need to overperform clinical duties and floor responsibilities in order to receive the same credit as non-underrepresented medicine peers. In the end, this group identified mentorship, setting objective standards for resident OR participation, and racial bias as areas of improvement. One of the more unique approaches to investigating barriers to autonomy was actually an exploration of how texting technology might impact clinical communication and decision-making. So this was a qualitative study using a constructivist paradigm out of UCSF. They identified ways in which texting might detract from trainee education, specifically regard to independence and decision-making. They identified several themes on the kind of new technocultural norm of texting as a common form of clinical communication, including informality, flexibility, accessibility, and tone. Of greatest interest to the topic of autonomy, texting facilitates flexibility, accessibility, tone, but also a shift away from analyzing and towards informing. So for example, one resident participant marked that in some ways, the increased degree of access to your senior residents has definitely made it easier to just be a reporter. I tell my junior residents all the time, no threshold at all. You can text me literally anything. Texting is also a poor platform for discussion and a poor translation of, it doesn't allow for good translation of nuance, context, and tone compared to conversations. Because of these limitations, it may be important to ask the question about whether reliance on texting might make it harder to access and assess readiness for graduated autonomy. One final barrier centers on the clarity of expected versus granted autonomy. So this is out of the vascular surgery literature. They surveyed vascular surgery training programs, and there was a significant discrepancy between the skills and knowledge that trainees deemed important and what was actually expected of them in reality. The most highly valued skill to earn autonomy that residents and fellows perceived for a case preoperatively was the case planning. This was across PGY levels, but only about 36% of attendings expected all trainees to perform this task. And the worst discrepancy was for interns, where 100% of interns thought that this was valuable to prepare for a case, and only 3% of attendings expected interns to perform any part of case planning. Both attendings and trainees, especially chief and fellow level trainees, felt that exposure of critical structures in the operating room was the most important intraoperative task to achieve autonomously. But this was expected less than 70% of the time by faculty. demonstrating a discrepancy between skills that everyone agrees are important and what trainees are actually expected to accomplish autonomously. With all that in mind, discussions about how autonomy is measured, whether or not trainees are prepared, and the barriers to equitable autonomy, I'd like to spend the next several minutes talking about some interventions that might promote better autonomy. We've got several examples to discuss, and then we're going to do a practice of one of these possible interventions. So up first is the concept of a resident-run minor surgery clinic. So this is out of Mass General. They designed a resident-run minor surgery clinic in 2014 and then followed it for a pilot year and 4 years after. It was a clinic run by PGY3 residents who were supervised by an attending. The attending staffed cases prior to the procedure, and then the attending viewed the surgical site prior to the wound being closed. They evaluated complications and unanticipated hospital admissions and compared the results to an attending cohort. In total, they looked at 340 operations or 341 patients that included 399 procedures. They were things like soft tissue mass excision, incision and drainage, skin lesion excision, skin tag removal, and even lymph node excision. There was no difference in post-procedural complication or admission rate between the two groups. The same group again looked at their outcomes 4 years later, and there was no difference in complication or admission rate. At this time, they also assessed patient satisfaction, which was very high for both groups. The only significant difference was that patients felt that the attending clinic procedure room was more comfortable at a higher rate than the resident procedure room. And they also assessed residents' confidence in technical and non-technical skills before and after completing the rotation. There was a significantly increased confidence across all skills except for administering local anesthesia and then incision and drainage, which both had already high confidence before the rotation. Their next steps are to incorporate performance data from this clinic into their evaluations and try to figure out how to translate the gains in autonomy in the outpatient setting into the inpatient wards. Another strategy for autonomy, but this one in the inpatient setting, is a designated chief service. So this is out of the program at Gunderson that studied their own chief resident service using NISQIP Quality and Training Initiative data, hypothesizing that residents on a resident-run service would have equivalent patient care outcomes to their peers who are not on a resident-run service and to chief residents who are both being supervised in a more traditional manner. They reviewed a total of about 1,000 cases and looked at 30-day outcomes. Overall, there were similar rates of any complication, unplanned readmission, and mortality. The resident-run service did have higher rates of renal failure, but lower rates of every other complication, including organ space infection, MI, pneumonia, septic shock, transfusion, and unplanned admission compared to PGY5 residents nationally. So ultimately, we found that patient care outcomes provided by chief residents on a chief-run service are comparable to non-chief-run service rotations with greater faculty involvement and PGY5 resident performance nationally. There's also strategies aimed at coaching. So Ohio State has an operative coaching program that they've been running for several years. They published their 4-year experience in 2023. The format is something that's integrated into their chief year. Chief residents designate somewhere between 6 and 12 cases throughout their chief year of training. They include things like laparobo cholecystectomy, laparopen inguinal hernia, laparopen ventral hernia, and laparopen partial colectomy. These coaches that are independent of the surgeon on the case observe the case without any type of intervention, and then the surgeon, the resident, and the coach debrief afterwards. They observed a steady progression in operative skill throughout the year, along with an increase in autonomy and prospective entrustments. Residents reported a positive impact on their learning, and attending surgeons reported that their involvement was also promoting their engagement in teaching in general. The biggest enhancement from the resident perspective was being able to receive neutral and authentic coaching feedback that was based on real-time observation. There's a couple representative quotes about residents who have participated in the program in terms of their positive experience. But coaching doesn't have to be from an attending to a resident. It can also be the peer coaching model. So at Mass General, residents completed a curriculum that's called the Surgical Coaching for Operative Performance Enhancement, or SCOPE curriculum. And then junior and senior residents were paired together. The structure then proceeded with the junior resident setting a goal for an operation. The senior resident then observed the case, and then both would complete a post-op debrief session, which was recorded. And assessed those recordings and found that residents used all the key principles of coaching, including goal setting, collaborative analysis, constructive feedback, and action planning. And they also found that the framework from the curriculum and the key principles of coaching promoted both prompted and spontaneous self-assessments, along with feedback on both technical and non-technical skills. Overall, resident participants felt that these coaching relationships offered them better feedback than their usual methods of operative feedback. In another shift of relationships, a group of the Boston VA healthcare system flipped the traditional relationship between faculty and residents in the OR. They performed a prospective qualitative study on interoperative reversal between surgeons and residents. So attendings, which all had greater than at least 8 years of practice under their belts, acted as first assistants for the entire operation, including positioning, preoperative timeout, prepping and draping, to actually performing intraoperative steps, communicating with staff and anesthesia, and then concluding the operation with a final debrief or timeout. They looked at a total of about 36 operations, including things like lipoma excision, port placement, partial colectomy, lap chole, and opening lower hernia repair. Residents at all levels had improvement in preoperative knowledge scores and intraoperative decision-making. Of the 36 cases, there were 25 intraoperative rescues performed by faculty. Most often these were done for failure to progress, so that was 23 out of 25 of those interventions, and most often that happened in lower hernia repairs. Overall, there were no differences in the duration of operations compared to typical durations for each of those surgeon participants' normal operative times. And overall, residents felt like this experience improved their preparation, confidence, autonomy, and intraoperative communication. There's also some new technologies that have the potential to facilitate high levels of autonomy, still with some degree of supervision. These include certain accommodations on the robotic platform for things like telementoring, but also other audiovisual recording technology that can be used for both open and laparoscopic cases. The one I'm familiar with from fellowship is Medtronic's touch surgery system. It records an entire case. We used it for all of our laparoscopic cases, uploads it to a cloud. You get immediate AI-guided case review. It breaks down every step of the operation, and you can review your cases on your own. The platform is also now integrated with audiovisual communication that you can hook up to talk to anyone, almost anywhere, over basically like a Zoom platform. So towards the end of fellowship, they were just rolling this out, and it meant that we as fellows got to do the case with our attendants sitting upstairs in their office, watching over the camera and talking to you in a headset that you were wearing. Overall, I had a really positive experience with it. I think it has great promise to offer high level autonomy in appropriate conditions and with appropriate supervision. And the last intervention is something that we're going to work on together right now, which is so this activity comes out of the Northwestern group, and their goal was to create a shared mental model of intraoperative performance expectations. They identified a group of core procedures, broke those procedures down into the essential steps, and then faculty assigned a level of anticipated or expected autonomy for each step according to the PGY level, using the Swish scale, which you are all familiar with from the simple apps. There was some variability in assigned autonomy levels across service lines, right? So like an outpatient elective cholecystectomy is very different from an ACS disaster gallbladder, but all of these were eventually standardized using a lens of an average case across a service line. Each of them were then distributed to both faculty and residents. After implementation and dissemination across service lines, residents reported improved satisfaction with understanding expectations and felt that they were able to get more specific feedback on the technical skills of a given case. So this is what those maps look like. No one is allowed to do laparoscopic cholecystectomy, but we're going to test our hands at making some maps of our own. So I'm going to have everyone get up and move around because we want groups of people that have both faculty, residents, and medical students. I know we have limited table space, but you can pick any operation you want. If multiple groups want to do the same operation, we can compare how people assign levels of autonomy. But your responsibilities are to break an operation down into no more than 10 steps. And then for each PGY level, you're going to assign an expected level of autonomy for each of those steps. This is going to be your guide. There are large pieces of paper on the ends of all the tables. There are some markers. If people have other markers, you're free to use them. But let's divide into groups.
Wonderful. How are you guys? Where's our picture? Green or orange?
In case you guys doing this. Yeah, join us.
Join us. What do you want to do?
Get one of those.
Autonomy.
Yeah.
For gastric cancer. You want to do
There's lots of paper over here. Some faculty want to trickle up.
over here.
Speak anything literally. You know, hopefully no duplicates.
No, duplicates are fine. Duplicates are fine.
What?
I think maybe like
That's good steps. Come back. Yeah, like the side.
Abdomen.
well, we can do something else.
No, no. Oh, God, ankle hernia.
Are you sure? We
Yeah,
can
Dr.
save it.
Ewing loves ankle hernia.
They already took all mine.
We've got another.
Okay, lap hernia.
Yeah, like
We'll do lap slash roll off.
That's a unit section of.
No, no. We're good.
Yeah, you can sit down.
Probably you should go on.
A robot.
I love a remote incision.
Good.
Actually, it's not like.
Who's the best handwriting? I guess we can have like one.
So.
Okay, remember we decided we weren't gonna do that.
We can definitely change it. I just did this before.
You guys know how to do. Yeah, he's about ready to do it. He's doing it.
Yeah, wow.
Residents over here, so I'm gonna ask that at least one of you, potentially two of you, go join this group.
Mesh selection.
Okay.
Your seat, okay.
All right.
That's liking.
Oh, we just picked a lap.
Mesh placement.
They're not.
It's incapable of writing.
It's so good.
Another step.
I've got a robot. Turner too, but I don't know.
Start off, I guess, check the field for stations. We gotta put a pin. I think it's like a big sticky.
It's just a sticky paper.
Maybe like a 2 to 5. Much better than me.
Exit station.
So that's a green.
You're supposed to have it.
It's pretty bad.
That can even be.
Non-critical stuff.
Yeah, it seems like it's positioning in there to now to determine like at what
Writing.
Standing can do it.
Well, she could.
Yeah. Let's go from the student. Are you comfortable?
Yeah. Oh, yeah.
That kind of
Like, what other things do you think?
Dr. Ewing's face was like this.
It's a, so we decide what level should decide to stay.
The residents.
Maybe we should get some instructions from Dr. Cassling.
So we have our steps right now.
Our steps.
For Robo and Gwen.
Fine.
So can we go through and decide what level?
Yeah, and maybe for abbreviation of time.
Like here, you're like.
Yeah.
Somewhere between PGY two,
Not
PGY
colors,
four.
but bad idea.
Don't pick a chief, but a mid-level person. What level
Finally,
of? expertise identify
I've seen, it is.
for that case with the state? So are they show and tell? Active health hazard?
They're going to move it in.
So like a PGY3, patient positioning should be.
So basically assign each PGY level. But because we're short on time, just pick one, somewhat either 2, 3, or 4, for which level of.
So then basically all of them.
I'll say
Or.
Did you have 4?
We're just gonna have
And then-
steps and then-
Oh, maybe we did.
Should be like supervision.
Yeah.
Yeah, I think-
Hernia reduction.
Should be able to.
Maybe some like passive help, the supervision only depending on like, you know, how big of a hernia this is. Just yanking on the sigmoid colon.
Passive health.
Wow, Dr. Sassy's just like.
Heart rate.
You know, what level?
I must have been careers, you know, I keep thinking that.
Yeah.
It's a good test every day.
Yeah. I had no angina unless it's something else. It's something else. It should be.
But you're doing it wrong.
Yeah, because I haven't done it.
We need to. This way.
I mean, if the third person's gonna do that, you should be able to do the whole thing.
Yeah.
PGY3 supervision.
Yeah.
Yeah, passive, same thing, right, depending on how challenging the case is. Hernia, maybe passive help.
Controls for yeah.
Yeah, I think so.
I started doing this a little bit.
So what?
last year, probably. Where are you going to
Yeah. Fixation. I think this can be done by PGY2.
Because it takes a while to understand.
Tie the knots.
Yeah. Yeah, with active help. I guess it's where we're picking one. What was that?
I think that
You said it only
one-
takes one.
One for like
PGY, so-
simplicity and we don't have a time, and one PGY. We wanna do for each step. Like for PGY two,
Know what size.
what level would they be for step 1, 2, 3, 4, 5?
So she just said she wants to.
With certain levels. I mean, a 2 could do. Probably that.
Just like inspect that.
Yeah, instead of doing each year, she wants her to pick a PGY year.
That's what we did, make it easier to get. Leave drain.
Does that make sense? She said like.
There
a
you
year.
go.
Yeah.
Yeah.
Say active.
Passive help to supervision only and then for.
2 minutes.
Same 5 days. Or 3D max.
Small.
I
Small.
would say I like that placement.
Well,
About 2 minutes left.
We know we're
slow.
Yeah.
No, everyone is like, they have 2 minutes and now it's like, you're fine, but 90 seconds.
All right, so mesh selection and placement, and then so
You
once
secure the
it's
mesh
secured,
close.
so.
Honestly, placing is harder than.
The act of putting a full.
I haven't really done
Removal actually.
PGY2.
I don't know if you're safer.
2 minutes to go.
Did you
You're done?
And then
Stick it up on the wall.
closing your flat.
There we go.
That's three.
And that's 3 supervision only.
Sorry.
Depends on the.
Okay, and then.
Yeah, I'd say passive.
Oh, we forgot to do capacity. We just never stuck up. They could have done all the stuff like docking the robot.
Yeah, this is the hardest. This here.
Hang this up.
Flip your work.
Yeah. Basically.
When everyone's done, 41 seconds left. Stick. Surgeon.
Repair my nose. Yeah, it's not gonna be.
Oh, yeah, that's good.
Sure, it turns.
Then you can say a mesh replacement.
Oh.
Like go through.
Might be something like-
Just stick it against the wall. Go stick it.
What was that?
Stick it.
Just stick it where it is. Somebody, you want me to put it up? Yeah, sure.
We don't know, Slash.
Okay.
Okay,
Nine is
we're gonna call it time.
nine is
wherever you are.
Mesh fixation.
You have to hang up your lovely
10 is
artwork.
I'm not sure how to fix it for them.
Okay, I'm
And
just
then
gonna-
put a color of the academic.
Oh,
Yeah.
obvious.
Soft and skin.
No, so I think they're cutting.
Soft and skin.
Okay.
Oh, someone
How
did
about
Robert
doing that
Mueller.
activity? It was harder than maybe anticipated. Limited time, let's write that as a limitation too.
And also take
Rudy is apparently.
I know, so it's great.
Did anyone find it really easy to assign a PGY year for each level of autonomy? So. How about making the steps? That took a long time. Right, so for our chiefs who are about to take oral board soon, make sure you know how to describe each operation in like definitely fewer than 10 steps, ideally 5 to 6. So that takes time, and then actually thinking through what you might expect for each PGY year is a little bit difficult, right? That's part of why addressing issues around autonomy are challenging, because everyone has slightly different views. So I hope I've been able to convince you that autonomy in residency matters. So in an era where there's multiple concerns about preparedness for trainee autonomy, there are multiple paths to take to strike the right balance. The challenge is that the balance, though, isn't the same for every program or even for every resident within a single program, but continuing to work towards that balance is critical for our patients and also for resident well-being. So the last study I'm going to talk about is one that was collected as a part of the post-app site survey. It was sponsored by the ACS and ACGME. They were looking at factors associated with perceptions of autonomy and how to characterize the relationship between autonomy and well-being. So unlike sessions on meditations and pizza parties, right, all the other kitschy wellness initiatives, this is something that I feel like we can really get behind. They found that about 82% of residents felt that they had appropriate autonomy and that they were less likely, of the residents who reported autonomy, they were less likely to report burnout, suicidality, thoughts of leaving their program. Women were less likely to report autonomy, which aligns with those barriers that we discussed before. And then residents were more likely to report autonomy if they also reported satisfaction with their workload, satisfaction with work-life balance, faculty engagement, resident camaraderie, and efficiency in resources. So ultimately, autonomy and well-being are inescapably linked, and this is substantiated by all of the qualitative results that they reviewed. So residents reported that autonomy in their practice gave them a meaningful experience. They derived meaning from direct patient care and spending time in the operating room, meaning from building relationships with patients, and conversely, with less autonomy, there was loss of confidence and loss of sense of purpose. Residents also recognize that autonomy isn't inherent, it's something that's earned, and it's based on developing those interpersonal relationships, improving worthiness and trust. Finally, residents in the survey highlighted the importance of double scrubbing as an activity and a behavior that builds camaraderie, develops peer relationships, and gets residents involved in bigger cases at more junior levels. Just like everything else we do from a faculty standpoint in an academic medical center, granting autonomy is about the patients and the quality of the care they'll be getting from our future graduates. It's also importantly about the residents. So I'm going to close out by showing you a picture of Dr. John Tarpley. Dr. Tarpley was a former program director at Vanderbilt. He's kind of an amazing general surgeon, but he also is very known in the global surgery world. He had several Tarpisms, so things that he would say quite often that I think are specifically applicable to the discussion around autonomy.
putting kind of all of these things together that we've talked about, from building trust, earning respect, and having people let you do more things. So they are, get in the habit of having good habits. Experience is inevitable and learning is not. Adversity is a given and misery is an option. And the getting is in the giving. So this is why I do this job, right? These are all the lovely people who let me take care of their patients and trained me to do so, along with my co-residents who helped me along that journey. So this is all why we do this. And in the end, we'll close out by just talking about how autonomy is difficult to nail down because it's multifaceted. There's significant value in soft skills that encourage trust. Residents have more to learn and prepare for than ever before, and the challenge of matching appropriate autonomy to that pace is going to be never ending. There are very real barriers to granting equitable autonomy, but there are also some very real opportunities that promote autonomy, with the most common theme being making the implicit components of how autonomy is granted explicit by setting clear expectations. And then I encourage all of us to continue to be engaged with how we grant and earn autonomy, specifically here. And that's all I have.
So much. Excellent presentation. I'm very proud of everything you do and thanks for everything. Questions for Dr. Cassling?
I know that this is not the highlight of your talk, but this Medtronic technology that you mentioned is really interesting. What are like some of the other applications you've heard of for that? I bring it up mostly because like with our rural surgery symposium and everything, it seems like there would be so many applications to like help with education of people who are already attending maybe in like.
Yes, definitely. I remember when I was looking for jobs, in the back of my head, I was thinking, oh my gosh, I would love if touch surgery was everywhere. So then if I needed something intraoperatively, call up, fellowship people and ask, hey, does this look right to you? Like, what should I be doing here? I think it has a lot of promise from like a telementoring standpoint. So being able to ask for a second set of eyes if you don't have that support literally in your exact same facility. So I think that has a lot of promise. And then also something that's available with other robotic platforms too, right? Being able to view the same operation from like a remote distance.
Dr. Singh.
Yeah, so now on the slide, you were saying that the new fellows coming for the fellowship training, only 2/3 may not be able to operate more than half an hour independently, okay? So mean the people, the graduates coming out of residency are not able to do their independent practice. That's for the like 80% of people.
Mhm.
So is this a system-wise problem or a site-specific problem, like people coming out of university setting are having this kind of problem instead of community care programs? Or is the whole of the ACGME and the American College of Surgery system is going in that trend, that the trend need to be changed?
That's a good question. I don't know if anyone has looked at data specifically from like academic affiliated or university programs versus community programs or rural programs. So that's an excellent question. I do think it's very multifaceted, right? Some of it is going to be program dependent. Some of it's also going to be resident dependent, right? So from the framework, 3 of the 4 of those things are very much soft skills, interpersonal skills. Some of it is personality, some of it is how you interact with people, right? Those are all the things that are very hard to teach, but super critical to not only learning, but also getting the trust of people that you're working with. So I think that is maybe a less looked at component because it's harder to look at, right? The technical skills, the operative case logs, all of those things are a lot easier to measure, but a significant component of getting autonomy and as a trainee is all those other soft skills.
So let me ask this question to your student, very Nick Tran. Hi, how do you feel? No, next year.
Yeah, I feel good.
Feel good, but you can do it?
I would hope so.
Okay.
I just
I mean, I won't know until I
Yeah.
scrub into my first case.
I signed the Kaiser papers, so.
Yeah.
And autonomy, another faculty respondent to the survey said, it's very uncommon for faculty to be truly autonomous, right? Like as a faculty member, you are also reliant on whoever's in the room, whoever is assisting you. You're reliant on questions you've asked behind the scenes. Like I'm a huge proponent of if you need help, ask for help. I've called multiple people in this room asking questions about patients, bouncing ideas off them. I am not an autonomous person. I don't know if anyone else agrees with that same sentiment, but it's all about
the context that you're caring for patients in, and those limitations and when to ask for help too.
Also, the autonomy, I think, depends on your own comfort level too. If the residents are working with 10 different surgeons, everyone have a different way of doing the same surgery. If you do according to the he wants or she wants it, he will give you the whole case. But if you do want to do the case with me, the other surgeon want it, I mean, let me tell you to do this way and next time you can do the whole thing. So that's also like we want to check on the residents, how comfortable you are in doing the thing before we can give you more autonomy. It's a delicate subject. A lot need to be done on that thing.
I have a question from Zoom land. This is Fitz Gibbons. Can you hear me? Can you hear me?
This is an excellent grand rounds and many things you mentioned resonated. So the minor clinic is actually a very interesting concept. When I was a resident at UC San Diego, the VA, the third years ran the minor clinic, the so-called lumps on bumps. And I mean, I've learned a lot from that clinic. And it was comforting to know that I can call the chief or the attending that day. So I fundamentally, personally, from my journey, I found that experience to be very beneficial. I also learned from this conversation, it made me think a lot about the observing. One of the many positive things when doing training at MD Anderson, the attendings were strongly encouraged to walk to each other's room and out of curiosity, so you go and peek into what Dr. Singh is doing. And what happens is that fresh eye walks in, and if you're struggling in a step, you'll ask someone, what do you think? And that fresh perspective will immediately go, why don't you open that plane over there or change the maneuver or use the following instrument? So, well, let me show you a different technique. And I think it destigmatized asking for help. So I fundamentally agree with you. I have a low threshold to ask for help or call for help. And I don't think that we should destigmatize it because we have a patient at hand. So I fundamentally agree with observing. And I think you learn by observing others after a few years. And I don't know what your thoughts about that.
Oh, definitely. I learn stuff from watching people operate all the time.
And what do you think? Do you think that learning increased after you've established some level of competency versus at the very beginning? And I've noticed there are travel fellowships for surgeons. And when I hear from the surgeons who went to Japan and watched the ATP surgeons do cases for transplant, they come back and they've learned a lot by virtually of working. Obviously, there's malpractice, they don't want to operate. But the fact that now they're PGY4 plus and went and observed an experienced surgeon, that learning experience was much more impactful than going much earlier.
Yeah.
So what are your thoughts?
I mean, I think it kind of lines up with some of the findings from the qualitative projects that I described, right? That double scrubbing is very important, particularly as a junior resident, getting introduced to the OR, showing your face, making faculty aware of who you are, that you're a member of the team, knowing that you're invested in that patient's care. And then as you're a senior, initially I was going to end this talk by saying, these are like my little pearls of like what I learned from being a chief resident and transitioning to a faculty member. I would encourage everyone, be nosy, go into people's rooms. You never know when it's going to be the last time you're going to see XYZ operation for however many years. And just that exposure, seeing how people do things differently, even if you're not scrubbed in, I think is still very valuable. And if you are scrubbed in, even more so.
I remember the students asked me in clinic, we have a clinic, can we scrub with you in the case? I said, can we watch this? I said, stop asking those questions. The answer is always yes. The answer is always yes.
Dr. Cassling, thank you so much. That's a separate story. But for the sake of being the devil's advocate, let's say the student or Dr. Shan works in the operating room and the mode completely changes. But Shan is just there to observe how even if Shan is self-volunteering to go participate, the fact that it's just Shan who came in the room, now what was going on suddenly changes. So I don't know what's your take on objectivity?
So that's all of those soft skills that are hard to be objective about, right? So all of like the relationship things,
taking, being responsible, showing your face, taking initiative, all of those things are harder to measure and show. And they're also harder to change if there's a problem with them, right? Personality related, differences between faculty and residents or between residents, those are a really hard thing to address. I think if you notice that there is a situation where if a certain person you don't get along with, or the mood changes when you get into the operating room, that's a sign that that needs to be taken probably out of the operating room, addressed separately from like an interpersonal relationship standpoint. But I do think the ways that you get autonomy and get more involved are being open to new experiences, showing responsibility, being empathetic, being honest. All of those things are like universal truths for any level of training, any attending.
Question for you, and this based on the case we did last week or a few days ago, central retroperitoneal aortic cable paraganglioma, and Dr. Schwabe did a very nice job. I think when I was there as a supervision only, and I was asking myself when I was driving back home, and the question is, it's harder based on surgeon's expertise when you move from a show and tell with your learners to supervision only, and I was asking myself, when did I make that transition in my career, letting the chief resident do completely versus I was doing most of it. So how do you comment about that? Because it varies based on the surgeon after their training, and then moving away from that into a less comfortable zone, if you will.
I think a lot of it is surgeon dependent. A lot of it is experience dependent. So the one study that looked at that role reversal model, right? Those were all surgeons that were at least 8 years into practice. So people who felt very comfortable probably letting people do things in an operation. I feel very much not like that right now because I'm brand new, right? I think the important thing is that you have the insight to recognize that it is a decision that you have to make when you're going to let people do more things. And I think it gets back to the point of making the implicit explicit. So going through in your head, okay, these are the steps of the case. This is where I would anticipate each level of resident to be. It's now on me to try to give up that responsibility and see what happens. So being reflective in your own practice and really assessing whether or not you're letting people do what they maybe should be able to do.
One more question. Oh, okay.
I was gonna say, how do we, in a way, more like objectively measure sometimes the differences between perceptions in the case? In a sense of like I think about, umbilical hernias I did as an intern where, the attending does the whole case with a hemostat and you're just boving between the hemostat. And as an intern, you think, oh my God, I did that whole case. Versus as a chief, if you're just boving between someone else's hemostats, you're like, well, you did the whole case with the hemostats. I was assisting you. And I think we've all, worked with people who, sort of operate that way. The attending sort of shows you everything to buzz and you buzz it. And they have the perception that they had you do the whole case. And how do we better measure and standardize what does it mean to do certain operations? What does that look like?
Yeah. I think that's hitting on exactly the point of why autonomy is so hard, right? Because it's very observer dependent and participant dependent, like what your experience actually is. And it's very level dependent, right? An intern is going to be very satisfied, like you mentioned, buzzing between the tines of a hemostat. That's great. They should be excited to do that. I think it really comes down to that same idea of making every single task within an operation something that is observable, measurable, and be explicit about what each person is going to be able to do. That nuance is not something you realize as a junior resident. You don't realize that the surgeon is moving the entire operating room around you to make the operation happen, but it becomes very prevalent when you are a 4 and a 5. I think one way is talking about it, right? Telling your junior residents about your experience in the OR when you were a junior and telling them this is maybe how you're going to expect things to change. But I really do think it comes down to making implicit things more explicit, measurable, talking about it. It's not going to be perfect.
Dr. Ewan?
I was gonna say, I think that it's easy to feel like you're ready for graduation and practice, skills wise, but the biggest like transition to end to attending it is actually the decision making. So Like, for me, it's much easier to let you do the entire case than to let you make every decision in a complex patient on your own. And that was the hardest thing. I think, you know, all of you who were here when Dr. Patel and I started, you would see us double scrubbing everything, and we wouldn't even scrub necessarily. We would just be watching. It's like, what do you think? Like, should I do a subtotal here? And it's like, yeah, just do that. Like, it's having that, like, that responsibility of having to make the final decision in a complex surgical patient. That's, like, in my mind, the hardest thing to learn for autonomy. So.
I agree wholeheartedly, and those conversations happen everywhere. Like, that is not something I appreciated as a teaching resident. Every attending is talking about everything behind the scenes to figure out, make sure they're doing the right thing for patients. So that's a skill too.
Okay, so.
Code blue, NICU, room 19. Code blue, NICU, room 19. Code blue, NICU, room 19.
I just had a question actually from Dr. Fitzgibbons. How do you relate increased resident autonomy and as it relates to informed consent? So I guess as
Cancel code blue, NICU, room 19. Cancel code blue, NICU, room 19. Cancel code blue, NICU, room 19.
I did not have enough time to talk about that particular component, but there have been people who have done qualitative studies assessing like the patient experience with residents in general. I can send you that paper if you're interested in it. The one that I'm thinking about did interviews with patients who overwhelmingly were like, yes, I would be interested in having a resident be involved in my care. I just want to know that they're going to be involved and what's expected of them. In terms of caring for them.
Not a question, I just have one like remark. The autonomy has a different layers too. Sometimes we're doing a case in the OR. You are deciding and you are doing your actions, like you are dissecting, you are doing the surgery is one part of autonomy, but your surgeon is deciding what steps to do next and you are doing is also a part of the autonomy too. So as you keep on increasing your experience, you will reach the level where you are deciding and doing it too. But on the second part of Dr. Alrafai comment, Nick Tran, if you will land up in a difficult case, please ask for the help. Asking for the help is not a sign of weakness. Think positively, it may be a learning opportunity that you can do this thing next time more comfortably. That's all it is.
Thank you so much. For everything you do, I know Dr. just joined, he sent his apology for not being with us, but on behalf of the residency and Patel, I was very proud of you. Can't thank you enough. Well done.
If any faculty are interested, they have published on general guidelines for enhancing autonomy. I forgot about that.
All right, everyone. Have a good weekend. Don't forget to RSVP.